Hello everyone, good evening. Let me know if my audio and video is good to go. Hello everyone, good evening. Hi Abhinandan. So party बनती है and party मिलेगी भी. Definitely party मिलेगी. And let me know if my audio and video is good. First please let me know if I am good to go. Just taking a couple of seconds so that everybody can join in. Definitely. Thank you so much, guys. Hi, Pooja, Ranjan. Right. So, what I used to say that shoot for the moon, even if you miss, you will land among stars. So, that is not only for the students, that is for every entrance examination aspirant, or that I used to tell to my daughter too, and that bring lot of blessings. So definitely, thank you so much for all your wishes. It really means a lot for me. Good evening, everyone. So, as promised, though a lot of guests are even sitting now, but what is promised has to be done. So, I am coming with the pearls of the ophthalmology, and there will be 100 most important pointers here, in which we are going to discuss those 100 most important things which are required for your ophthalmology, right? So, we will be doing it in Yes, we will be doing it in two parts. So let's get started. Are you ready, guys, for this ophthalmology, right? So let's get started with the pointer number one. So here I have just taken the derivatives of neural crest. Though all the derivatives are important, but here I am precisely taking the derivatives of the neural crest, which are most important. So neural crest, say what are the things which are coming. One important thing is the sclera. Whenever I say sclera, it has to be neural crest, all except the temporal sclera. Then we have the choroid, है ना? Choroid capillaries are coming from mesoderm, while the choroid stroma is coming from the neural crest. Then we have endothelium, that is corneal endothelium. That is the corneal endothelium. So when I am talking about only endothelium, it is actually mesoderm. But when I am talking about corneal endothelium, then it is the neural crest. So apart from these three things which are most important, we have the orbit. We also have the trabecular meshwork. So trabecular meshwork kya hai? Trabecular meshwork is a sieve like meshwork through which the drainage of the aqueous humor is going to take place. And we are also having the ciliary muscle. Now yes, ciliary muscle is very important, and this is a recent PYQ also, which has been asked in the NSET examination. So we have sclera, we have choroid, stroma, we have corneal endothelium, all of the orbital tissues, trabecular meshwork, and the ciliary muscle. All this is coming. Yes, stroma of the other places is also coming from here. Like apart from the choroid stroma, we have the corneal stroma, we have iris stroma, scleral stroma, we have the scleral stroma also, ciliary body. All the stroma is coming from the neural crest, right? This is your pearl number one. Now number two, which is again very important, especially for the this is especially focused for the FMG examination, but it is useful for the NEET PG as well as NCET examination too, because high yield topics are always the same. So number two is the diabetic cataract, and it has been seen that after the senile cataract, the most commonly asked cataract is the diabetic cataract. So first of all, you should know one is the most common cataract in diabetes, and one is the metabolic cataract. and one is the metabolic cataract in diabetes. So diabetic cataract mein most common is the pre-senile cataract, and metabolic cataract is the snowflake cataract. Now, never get confused that snowflake cataract is the most common cataract. No, it is not the most common cataract. Most common is the presenile cataract. Metabolic cataract is the snowflake cataract. Now, two important things about this snowflake cataract. Number one is the aldol reductase enzyme. So, it is taking place due to the aldol reductase enzyme, a very, very important pointer. And second is the pathway. It is taking place through the sorbitol pathway. So it is due to the enzyme aldol reductase, then sorbitol pathway. And yet another important thing is that whenever we have that diabetic cataract, we will have fluctuation of refractive error. These are the most important points that you should know. Aldol reductase enzyme is there, fluctuation of the refractive error. We are getting the fluctuation of refractive error. Whenever we are having this word fluctuation, always go with the diabetes. Then next is the traumatic cataract. Now trauma is one topic which is coming every single year in your examination. So traumatic cataract may, it can be blunt trauma. Blunt trauma is the most common. It can be penetrating trauma also. It is penetrating trauma also. So in the blunt trauma, we will have the rosette cataract. This is the rosette cataract, which is also called as the stellate cataract, star-shaped cataract है. Penetrating trauma से we will have the sunflower cataract. We have the sunflower cataract. Now sunflower cataract के we have other causes also. So whenever I'm talking about sunflower cataract, it can be penetrating trauma. It can be Wilson's disease, or it can be the copper deposition also. It can be the copper deposition. So whenever you know there is some copper deposition, it can be due to the Wilson's disease also. It can be due to any other thing also. That is called as the chalcosis. So in this session, I have not included the images because image-based session we are going to deal separately. Right. Then next is your KF ring. So definitely KF ring is yet another important topic where we have the Kaiser Fleischer's. Kaiser Fleischer's ring hai, KF ring. This KF ring is actually reversible. Number one important thing is it is reversible on the treatment. It is reversible on the treatment. It is golden brown in color. It is golden brown in color. It is deposited in the Descemet's membrane. In the Descemet's membrane of the cornea. Reversible on treatment. It is golden brown hair, Descemet's membrane of the cornea, and first it is present in the superior and the inferior quadrants of the inferior quadrants of the cornea. And another important thing is that whenever we have the Wilson's disease, I can have this KF ring. So 50 to 55% is found in the liver diseases. So any patient who is having liver diseases in the Wilson's disease will give me half of the patients, and 90 to 95% in the CNS diseases. 50 to 55% in liver diseases and 90 to 95% is occurring in the CNS diseases. All right. Now, another important thing is bacterial endophthalmitis. Now, you know, these 100 things that I am talking about are the 100 most important topics in Ophtha, and usually the question will be curated around them. So, I am trying to deal with the 360-degree aspect of that particular topic. Bacterial endophthalmitis may here basically I am talking about the post-operative bacterial endophthalmitis. It is the most severe, that you can say most severe overall most severe. Overall may we have intraoperative also, we have early post-operative also, we have late post-operative also. Most important, most severe overall complication of the cataract surgery, of the cataract surgery, where the patient will always present with a sudden. Now, how can you diagnose a patient who is having bacterial endophthalmitis? We will have sudden and painful diminution of vision in the post-operative period. So if my patient is coming with a sudden painful diminution of vision after the cataract surgery, a lot of redness will be there, pain is there, watering can be there, hypopion, a very important thing, hypopion, that is the pus in the anterior chamber, that can also be there. Then they can also ask you a question related to the etiology of this endophthalmitis. So always look at the onset, whether it is early onset endophthalmitis, or it is late onset, early onset or late onset. So early onset will be caused by the staph epidermidis, okay, and the late onset will be caused by the propionibacterium ignis. So definitely they can ask you about the clinical scenario, cause, or bacterial endophthalmitis itself can also be there. Now, next important thing is the keratome. So there had been multiple chances where they have asked a question related to keratome. This keratome is a blade, something like this, where we are having an angle of 45 degree, okay, while another blade is also there, that is having an angle of just 15 degree. This is the side port blade. This is the side port blade. So one is the keratome blade here, and one is a side port blade, and both of them actually are used in the phacoemulsification. Both of them are used in the phacoemulsification. So whenever we are doing this surgery, suppose this is the cornea, two kind of incisions basically we have to give. One is your main incision, and one will be the side port. So main incision, this one is A and this one is B. So this A is given by keratome, which is a main incision, and size here is 3 to 3.5 mm, 3 to 3.5 mm. While if I talk about the side port is given, this is given by B, side port blade, and this is about 1 mm only. So basically in order to give the sutureless incision, we could have given only one incision also, but then we would have to enlarge that incision. So instead of giving one large incision, we are giving two small incisions. One is the main incision through which we are doing the phacoemulsification. Here we are doing the phacoemulsification, and one is a side port where we are doing the irrigation and aspiration. We are doing the irrigation as well as aspiration. This is done through the side port, and due to this, phacoemulsification is a sutureless surgery. Therefore, it is a sutureless surgery, right? Now, another important complication of the cataract surgery is the PCO, that is your posterior capsular opacification. And there are many questions over this. Posterior capsule that we are leaving is also getting opacified. It is after about around 1 year of the surgery. After about 1 year of the surgery, we are having the opacification of the posterior capsule, and therefore it is also called as after cataract or the secondary cataract. Therefore also called as after cataract or the secondary cataract. And there are two types of this cataract, like we can have the Somering's ring cataract, or we can also have the Elshing's pearl cataract. Somering's ring cataract can be there, Elshing's pearl cataract can be there, and treatment is same for both. That is your Nd:YAG laser posterior capsulotomy. So who will tell me the wavelength of Nd:YAG, mechanism of Nd:YAG? Wavelength of Nd:YAG, guys, is 1064 nanometer, and mechanism will be the photo disruption. So I am sure without a doubt that these 100 pointers are definitely going to cover all the questions that are coming in the ophthalmology. I cannot have a question which is not inside these topics. So definitely, if you have already grasped the concept and you are doing these, then that will definitely be helping you. Now another important thing is ectopia lentis. Now ectopia lentis may we are having the ectopia means abnormal. So we are having the abnormal position. Ectopia means abnormal position of the lens. So why we are having the abnormal position of the lens, which is due to subluxation. So this is associated with the congenital anomalies, associated with the congenital anomalies. Whenever we are having the abnormal position of the lens which are associated with the congenital anomalies, then that is called as ectopia lentis. Like number one, we can have Marfan syndrome. Can you tell me what is the type of subluxation in Marfan syndrome, type of subluxation in homocystinuria, type of subluxation in the Ehlers-Danlos syndrome, and type of subluxation in the Weil-Marchesani. These are the important causes of the ectopia lentis. What is the kind of subluxation which is occurring in the Marfan syndrome? Is supratemporal subluxation. So here we are having fan is supro, okay, and here we are having urea will be your infero, therefore this will be inferonasal subluxation. Very good. Then we have Ehlers-Danlos syndrome, where we are also having the blue sclera. Subluxation can be any direction, but we are also having the blue sclera. And wheel marchesani march past है, इसीलिए एंटेरो inferior subluxation. So one kind of subluxation can definitely be asked from you people. And we always have this doubt what to leave, what to study, what all is important, how to study, and सबसे बड़ी चीज how to recall. So I have come with this solution where you are having the most important 100 topics, and you know what questions are important, what questions have come over this, and what can be asked also. I am good. Thank you so much. So now our famous Bablu hai. We have this Bablu, and I would like to remind you about our famous mnemonic, that is your blue baby boy and Bablu. Blue baby boy Bablu is there, where we are having the blue sclera. Baby is less than 3 years hai. Then more common in boys है, B for bilateral also है, and Bablu is the name. This is the mnemonic for congenital glaucoma. This is the mnemonic for congenital glaucoma, blue baby boy Bablu, or the ophthalmos है, where the baby will come with the BPL card. BPL card है, that is below poverty line card hai. So any baby less than 3 years of age with the boy with bilateral involvement is coming with the blepharospasm. Is coming with the photophobia, coming with the lacrimation. This is the constant triad that we are going to get, is having the blue sclera also, is having the Miguelo cornea, is having the hazy cornea. Then you are sure that you are dealing with a case of congenital glaucoma, along with the Habs stria also, along with the Habs stria. So H for Hab and H for horizontal, don't forget. H for Hab and H for horizontal striations are there, right? So very easily we can differentiate that this baby is having the ophthalmos. Next is your visual field defects. So visual field defects, basically I am talking about the primary open angle glaucoma. Visual field defects in a patient of primary open angle glaucoma, you should always know the sequence. And for this we have a mnemonic in corona. B, P, should, P, W, doubly tested. In corona, BP should be doubly tested. So in corona means we are having the isopter contraction. We are having the isopter contraction. Then we have B for bearing, bearing of the blind spot. Then we have P for paracentral, P for paracentral hai, and also remember that this is the first significant scotoma. So why this is the first scotoma which is significant? Because these two are not significant. These two are not significant. They are just non-specific हैं, earliest हैं, peripheral हैं. इसीलिए the first significant scotoma that you are going to get is a paracentral scotoma. Then we have siddle scotoma. Siddle scotoma is a sickle cell. It is sickle cell shaped. Then we have Jerem scotoma. Jerem scotoma is also called as the arcuate scotoma. Jerem scotoma is arcuate scotoma. Then we have the double arcuate. Then double arcuate scotoma, and then we have T for tunnel vision. And finally, we also have the temporal field. Which field is last to go? Temporal visual field is last to go. Which visual field is last to go? It is the temporal visual field which is last to go. Okay, so learn just the sequence, and I am telling you that you have learned so many questions. The first significant scotoma, first two scotomas which are not significant. This is there, sickle cell scotoma is there. Then Jerem scotoma, what is Jerem scotoma? That is there. Then tunnel vision ka DD. Then temporal visual field is last to go, that also. And last but not the least guys, last but not the least, arcuate and double arcuate ki wajah se we have the nasal step, Roini's central nasal step. So I know most of the people panic listening the nasal step. Ma'am, what is this nasal step? So arcuate hai and double arcuate hai na. So you can always jump from a smaller arc to larger arc. That is a nasal step. It is nothing in itself. It is just the unequal contraction of the horizontal arcs. That's it. Nothing much. So don't confuse. Okay. Don't panic about it. Up. When we are talking about the primary open angle glaucoma, how can I miss the optic disc changes? So there was a question also on optic disc changes in the INISET paper. So let's get started with the optic disc. देखो सबसे पहले what is normal? Normal CD ratio, if I talk about, is 0.3 to 0.4. Okay, so the cup to disc ratio is 0.3 to 0.4, and we have a thick neuroretinal rim. So slowly and gradually we will have cupping. What is cupping, guys? Cupping is the increased size of the optic, the CD ratio. That means from 0.5, then 0.6, 0.7, 0.8, 0.9, and total cupping. In this way we will have cupping. Now because the cup size is increasing, we are also having the thinning. We are also having the thinning of the neuroretinal rim. Then we have number 3. We have also what is you called as a vertically oval cupping. So the shape becomes vertically oval. That is called as the vertically oval cupping. We have the what you called as the asymmetrical cupping. Now what do you mean by asymmetrical cupping? See, cupping is there in both the eyes, but it is not symmetrical now. One eye may be having 0.6, another can be having the total cupping. So that is called as asymmetrical cupping. And we are also having hemorrhages over the optic disc. That is called as the splinter hemorrhages. Whenever optic disc pressure is very high, then we are having the splinter hemorrhages. And finally we have the optic atrophy. What is the type of optic atrophy which we are getting here? The type of optic atrophy is the cavernous, cave-like optic atrophy hai, called as the cavernous optic atrophy. Right, guys? Now coming to very important thing, that is acute red eye. Now whenever I am getting a question on acute red eye, the type of vision loss is sudden and painful. The type of vision loss is sudden and painful diminution of vision. And we can have two causes of this. I can have acute congestive glaucoma also, and I can have acute anterior uveitis. Now the major thing is, how can I differentiate? So I will tell you so many things, but first of all, the most important thing is, look at the pupil. This is most important. And there was a question in NEET PG 2024 also in relation to this. So if you look at the pupil of glaucoma, there will be mid dilated pupil. We will have the mid dilated pupil, but when you look in the uveitis, it will be a miotic pupil. So here we are having mid dilated pupil, and here we are having miotic pupil. Apart from that, acute congestive glaucoma is more common in females more than 50 years of age. Diabetes, hypertension, Vox triad will be there. Vox triad will be there. Colored halos, not to forget the colored halos. So each and everything is important in order to differentiate. Whenever you are in a first, how to differentiate, you can easily look at these things. And here we are having miotic pupil. Earliest sign will be aqueous flare, aqueous cells will be there, KPs will be there, more common in the young males, and very important thing is that in cases of uveitis, we will have lot of systemic associations also. So the reason is that, uveitis is not infective. The most common etiology of the uveitis is autoimmune etiology or the allergic etiology. And that is the reason we have so many systemic associations. Like, can you give me an example of systemic associations? I can have Behçet's disease. Behçet's syndrome can be associated. Ritter's syndrome can be there. Ritter's syndrome, reactive arthritis can be there. Toxoplasmosis, VKH syndrome can be there. Then toxoplasmosis can be there. Sarcoidosis. So these are some of the important diseases which can be found in relation, and obviously all these syndromes we do study at one place or another. So sarcoidosis can also be related with uveitis. Behçet's disease can be related, especially with the acute anterior uveitis, right? Now coming to a very important thing, and again this is your NEET PG 2023. There had been a question related to it. So if they are asking me about uveitis along with some kind of arthritis, then what kind of answers we can give? Like, I can think about ankylosing spondylitis. Okay, now again, ankylosing spondylitis we do study. It is common in young males. है spine movement है, HLA-B27 है. We can have what you called as the Ritter syndrome, reactive arthritis. Just now I told you. We can have psoriasis, psoriatic arthritis can also be there. We can have somebody was writing also IBDs. So IBDs mein matlab this patient can come with acute abdominal cramps hai, bloody diarrheas hai, blood and mucus in stools hai, surgery ka association can be there, derma association can be there, ortho association can be there. So I can have what you called as ortho. I can have I can have derma association, I can have surgery association, I can have the pediatric association also, because this patient can be having juvenile chronic arthritis, or the juvenile rheumatoid arthritis can also be there. Okay. Now the systemic associations that I was talking about here, I will elaborate them. Like, number one, if I am having a patient of Behçet's disease, guys, what will be the triad? So this patient can come with ulcers. He can come with oral ulcers. Along with this, we will have genital ulcers, oral ulcers, genital ulcers, along with the acute anterior uveitis. This patient can be there. Then number two, we can also have the Ritter syndrome. Ritter syndrome, whenever I want to make this diagnosis, I should have the triad. Of Ritter syndrome, where we can have the urethritis is there. We have arthritis. and we also have the conjunctivitis. So you must be thinking that the third part is the uveitis, but actually third part is not uveitis, rather it's conjunctivitis with or without uveitis. Uveitis may or may not be there. Then number three, we can also have what you called as the uh, toxoplasmosis. Now, whenever we are talking about toxoplasmosis, always remember the headlight in the fog appearance. Always remember headlight in the fog appearance whenever you are thinking about sarcoidosis. This is also important. Whenever you are thinking about the sarcoidosis, then you have to think about the panuveitis. That, because whenever, most of the times, like I am talking about most of the times, whenever I am talking about sarcoidosis and it's a granulomatous disease, I will have the granulomatous kind of panuveitis. Then I will have the granulomatous kind of panuveitis, and a very important finding that we will have is the candle wax drippings. So each and every word of this aspect is important, and I have written it. Okay, headlight in the fog appearance, candle wax drippings, these all are important. Now the next important aspect is the differentiation between episcleritis and scleritis, and on the same aspect we are going to discuss the differentiation between the conjunctival congestion as well as the circumcorneal congestion. So this is again a very important aspect whenever we are getting a question, because both are common in females, both are associated with the rheumatoid arthritis, or any connective tissue disorder. Both are having the diffuse variety, which is more common than the nodular variety. So this is common in both. So how can I differentiate? Differentiate में episcleritis is actually superficial, and scleritis is deeper. Now on this basis the color will be different. This will be bright red. This will be bright red color. This will be bluish color, violet color. Okay, whatever is written there. And a very important thing is episcleritis is painless. So in the question you can easily differentiate whether it is episcleritis or it is scleritis, whether it's painless or it is very painful. So I think this is going to help you a lot when I want to differentiate. I can look at the pain. When the patient is having episcleritis, there will be no mention about pain. But if the patient is scleritis, you cannot have a question without pain. Pain hoga hi hoga. Pain, deep boring pain hai. Patient awakening from the pain. Patient wakes up from sleep due to pain. All these things will be there. And number four is that there will be no scleral edema. Episcleritis may there will be no scleral edema, but in scleritis this will be present. And though it both can be associated with rheumatoid arthritis, but in scleritis it is more common. And the most important, most important is the blenching. Always check for the blenching with the phenylephrine. When I talk about the blenching with the phenylephrine, it is present here but it is absent here. This is the number 5. Now what is blenching with the phenylephrine? Phenylephrine is a vasoconstrictor hai, and whenever I am giving a vasoconstrictor, I can see that there is improvement in the congestion, but that improvement will be present in episcleritis and not in scleritis, because my vasoconstrictor cannot reach to the deeper area. This is again a very important question, innocent PYQ. And whenever you are having some fuss hai na, that what should be the answer, this will be our ultimate savior. And on the same lines we can also differentiate between the conjunctival congestion and the circumcorneal congestion on the same lines, because conjunctival congestion will be superficial while circumcorneal is deeper. Therefore the color will also be same. Here conjunctival may it will be bright red color, while this will be bluish color, you can say. And where they are present, that will be also different. This will be present in the cases of conjunctivitis, superficial hai, while circumcorneal will be present in the acute red eye. Now we have already discussed the causes of the acute red eye hai, acute anterior uveitis, acute congestive glaucoma. That means if they have told you that's a case of acute congestive glaucoma, you already know that we have acute red eye. If they have not given they have given you the features of acute congestive glaucoma, then also you know that you will be having the acute red eye there. Then another important thing will be the distribution. So this will be dendritic pattern, tree like arborizing pattern you can say, while this will be radial pattern. And radial will be around the limbus. This is radial around the limbus. But when I am talking about the dendritic pattern here, tree like arborizing pattern here, this is away from the limbus. This will be away from the limbus. And as I told you before also, the blenching is the most important thing, blenching with the phenylephrine. So when I talk about the blenching with the phenylephrine, it is absent here. It is present in the superficial, but it is absent in the deeper one. So again, this is the savior. If they have given you the blenching, then that is the most important thing. Another important difference will be the difference between the infections of herpes simplex virus and the herpes zoster. Herpes simplex is simple. Simple means only topical. Here we are having only topical features, while in the herpes zoster we are having the both systemic also, है ना? So basically here we will have first systemic, then we will have cutaneous eruptions, and then I have ocular features. While if there are only topical features, go with the herpes simplex, point number 1. Point number 2, here I will have true dendrites. Here I will have true dendrites. True dendrites means we will have tree like arborizing pattern है, something like this. Always see we have the norms also, we have the floor also. This is the floor and these are the norms. So norms will be present in cases of the true dendrites, while here we will have pseudodendrites. Here we have the pseudodendrites. Pseudodendrites may I will not have the norms. You can differentiate by this. So this patient obviously will be more sick in herpes zoster. He is having systemic features and it's a very painful, very painful condition. A patient can go into depression. Patient is showing eruptions in the distribution of the fifth nerve. Patient is showing ocular features. Here we are having characteristic as true dendrites. Here we are having pseudodendrites, and along with this we are also having the nummular keratitis. Along with this we are also having the nummular keratitis, where we will have the coin shape area. So if you see, there is a clear cut demarcation between the herpes simplex and the herpes zoster, and we can easily diagnose. So one important thing is which they had asked in the NEET PG 2023 was the name of the stain and name of the filter. So name of the stain here which is used is the fluorescein stain along with the cobalt blue filter. It is the fluorescein stain along with the cobalt blue filter is also there. Then we have the keratitis. Keratitis may, most of the times they are asking the question on fungal keratitis, and most of the times they are confusing with the bacterial symptoms. So that is why I took the advantage of both. देखो, bacterial may always remember that symptoms are more than signs. Okay, symptoms are more than signs, and fungal may signs are more. Signs are more than the symptoms. First important thing. Then number 2, bacterial may you will have lot of vascularization, and because of this vascularization we will have the lot of chances of perforation also, while both are absent in fungal ulcer. Another important thing. Number 4 thing is that in cases of bacterial we will have acute anterior uveitis, so it will present as acute red eye. Okay, so reddish hai, and acute anterior uveitis will be due to the macrophages. While if I talk about fungal is just the opposite. No vascularization, no perforation, no red eye. We are having grayish ulcer. We are having dry looking. Grayish hai, dry looking ulcer hai, and again, the savior will be the hypopion. So if you are in some confusion and they have given you the hypopion, you can always see hypopion of bacterial will be sterile also and mobile also. It is sterile, it is mobile, while here it is non-sterile and non-mobile. So this is again a savior which will help you in differentiating between bacterial keratitis and the fungal keratitis, guys. Now, another important thing is keratoconus. So, one important thing that I'm expecting in keratoconus is the pantochem. So nowadays, though image I will show you in image based session, but pantochem is one thing which they are asking continuously, which is helping you to look at the surface of the cornea. So whenever we have to look at the surface of the cornea, we can see the pantochem where we are having the conical protrusion of the cornea, and due to this conical protrusion the patient is having myopia because of the increased axial length. We are also having the astigmatism, we are having the myopia along with the astigmatism. So these are the presenting signs. Along with this, the tip of the cornea can present as the oil droplet, reflex. Patient can present with the scissors reflex. So all these reflex are very very important. Scissors reflex is due to the astigmatism. The type of astigmatism is the irregular astigmatism, and we also have the Fleischer's ring. Now don't confuse this Fleischer's ring with the KF ring. KF ring was due to copper deposition. This is due to the iron deposition that was associated with the low levels of ceruloplasmin. This is associated with the keratoconus, and last but not the least, we are also getting the Munson sign. Last but not the least, we are also getting the Munson sign here. Now, what is a Munson sign? Munson sign mein, whenever the patient is looking in the downward gaze, we will have the localized bulging of the lower eyelid. So, localized bulging of the lower eyelid when the patient is looking at the downward gaze is called as the Munson sign. Next is the keratoplasty. So again, I am expecting a question on keratoplasty in 2025 where we are having the corneal transplantation. This keratoplasty can be partial thickness also, or it can be total. So either we are removing whole of the cornea and we are replacing it with the whole of the cornea, or we are giving just the layers. So if it is partial, then it is called as lamellar keratoplasty. Total is called as the penetrating. This is called as the penetrating keratoplasty. So we have PK, penetrating keratoplasty, or we have LK, that is your lamellar keratoplasty. Now this lamellar keratoplasty can be divided into anterior lamellar keratoplasty, posterior lamellar keratoplasty. It can be ALK, it can be PLK. Anterior lamellar keratoplasty can again be divided into superficial as well as deep. Superficial and deep. So I can have superficial anterior lamellar keratoplasty. We can have deep anterior lamellar keratoplasty. Superficial kya hai? Superficial is up to the stroma. Up to the stroma, and deep is more than anterior lamellar is up to the stroma, and after the stroma it is deep. Now if this stroma is less than half, then it is less than half, it is superficial, and if it is more than half, then it is deep. So most of the time they can give you a section of the cornea, they can show you how many layers they are giving, and according to that you can decide. Or they are telling you that they have given only the first second layer, they have given up to the stroma, they have given 75% of stroma. That way also they can be asked. So you should know these terms. We are having lamellar keratoplasty, penetrating keratoplasty, ALK, PLK, superficial as well as deep. The different kinds of keratoplasties are there. Next is the congenital dacryocystitis, which is always important for its treatment, and we know that the treatment of congenital dacryocystitis is always given age wise. So number one, if age is 0 to 1 year, anything between 0 to 1 year may I can do the lacrimal sac massage. Can you tell me the name of the massage this? And sath mein we can give the topical antibiotics also. We can give the topical antibiotics. So when I am doing the massage, basically we are using the little finger, and the name of this massage is the Krigler's massage. The name of this massage is the Krigler's massage. Then next, between 1 to 2 years, I can do the syringing. Now, syringing kya hai? Syringing we are actually doing with the normal saline. What could not be opened, that membranous occlusion by the massage can be opened with the help of syringing. Then next is your between 2 to 3 years. 2 to 3 years may I can do probing. Probing, this probing, basically we are using the lacrimal probes. We can take it inside, we can open it, and between 3 to 4 years, between 3 to 4 years may I can do alternate syringing and probing, alternate syringing and probing, because it is only after 4 years that we can do the DCR surgery. Surgery we cannot do before the age of 4 years, so we have to wait for it. So always remember, this is the order of the treatment. Then next is the ptosis. First of all, what is ptosis? This is the drooping of the upper lid. Whenever there is a drooping of upper eyelid, that is called as ptosis. And in cases of myasthenia gravis. Now, whenever we are having the ptosis which is due to the myasthenia gravis, three important things we should always see. Number one, it should be asymmetrical. The amount of ptosis in the two eyes will be asymmetrical. It will have easy fatigability. We will have the easy fatigability of the muscles, as well as number three, we will have the variability. So the amount of ptosis is variable in a day. Then also it is due to ocular myasthenia gravis. When it is asymmetrical between the two eyes, then also it is due to myasthenia gravis. And when the muscles are having the easy fatigability, that time also we can have. Then next is the jaw winking phenomena. So basically this is called as a Marcus Gunn jaw winking phenomena hai, where a simple thing is that there is a improvement of the ptosis. There will be improvement of the ptosis with the opening of mouth. With the opening of the mouth, whenever we are having the contraction of the jaw muscles, there will be improvement of the ptosis, there will be retraction of the upper eyelid. That is called as the Marcus Gunn jaw winking phenomenon. While when I am talking about the proptosis, where we are having the forward ectasia, so proptosis may, you have to see whether we are talking about the proptosis in children or in adults. Adults may, it's very simple. You have to think about the thyroid eye disease. Whenever we are talking about the proptosis in cases of adults, always think about the thyroid eye disease, whether it's unilateral, bilateral, male, female, everything, any kind of thyroid status also. But when it comes to the children, then it could be unilateral or it can be bilateral. Unilateral may, it is the orbital cellulitis. It can be orbital cellulitis, and if it is bilateral, then think about the metastasis. Then it is metastasis which is coming from the chloroma, which is AML, coming from chloroma, as well as the neuroblastoma. As well as the neuroblastoma. So we have the cause for unilateral also, and we have cause for bilateral also. And with respect to proptosis, another important thing is how to differentiate whether it is due to cavernous sinus thrombosis or due to the keratoconus fistula. Cavernous sinus thrombosis may, I will have unilateral proptosis, and from this unilateral proptosis it can become bilateral in 50% of the cases. In 50% of the cases it will become bilateral, plus you can get history of cellulitis. I can get history of ethmoidal sinusitis. Ethmoidal sinusitis can be there, as well as history of the infections from the dangerous areas, of the face can be there. While if I am talking about the keratoconus fistula, here you have to remember that we will have the pulsatile kind of proptosis. So anything which is showing me pulsatile kind of proptosis, you have to think about keratoconus fistula. उसके अलावा I also have chemosis, which is the edema of the conjunctiva. I will have chemosis, and number 3 is a brew where I can have the noise in the head. So both are around the cavernous sinus, both will have proptosis, both will have ophthalmoplegias, both will involve the contents of the cavernous sinus, both will have the diplopias in the lateral gaze 6 nerve. But I have just written the most important points which will help you in differentiation between the two. Then next, now 3 important triads हैं, triads of congenital rubella, congenital toxoplasmosis and congenital syphilis. Rubella में we have cataract, we have sensorineural hearing loss, along with this we have PDA. While toxoplasmosis में we have hydrocephalus, we have the hydrocephalus, then we have chorioretinitis. Chorioretinitis is there, along with we have the intracranial calcification. Intracranial calcification. While the triad of congenital syphilis may we have the peck-shaped teeth, we have sensorineural hearing loss, and we have interstitial keratitis. So I think these 3 triads are most important and very typical hai. They can ask you about interstitial keratitis hai, peck-shaped teeth hai, hearing losses hai, chorioretinitis, headlight in the fog appearance. Like this congenital toxoplasmosis was asked in NEET PG 2024 mein, this was asked. Then we have the next one. Here some of the important things about the anti-glaucoma drugs, like the most commonly used is the beta blockers. Most commonly used are the beta blockers, while the drug of choice of the open angle glaucoma. Drug of choice of open angle glaucoma will be the latanoprost, or you can say the prostaglandin analogs. Drug of choice of the normal tension glaucoma is the bitoxolol. Only drug which is neuroprotective. Only drug which has neuroprotective will be the brimonidine. Only drug which is neuroprotective is the brimonidine. I'll write with a red color. Will be the brimonidine. Very, very important. Now, optic, this changes in primary open angle glaucoma. This we have already dealt. So I'll be continuing here with the anti-glaucoma drugs. Anti-glaucoma drugs may another important thing is that which drugs are contraindicated. Like for example, which anti-glaucoma drug will be contraindicated in? Number 1, if there is cystoid macular edema in my patient, which anti-glaucoma drug should be contraindicated? It should be prostaglandin F2 alpha analogs. Number 2, if my patient is having bronchial asthma. If my patient is having the bronchial asthma, then I should ignore non-selective beta blockers. We should not give. These are contraindicated. Thank you so much, Saransh. Thank you. Number 3, if the patient is having acute pulmonary edema, then I should not give mannitol. And if my patient is having hypertension, systemic hypertension is there, then I should not give the alpha adrenergic analogs. And number 5, if my patient is having the sulfur drug allergy is there, then I should not give the carbonic anhydrase inhibitor. So again, a lot of questions which have been asked from this. Then next is the Goldman's applanation tonometer. We have the Goldman's applanation tonometer, which is actually the gold standard tonometer. It is the gold standard tonometer hai. And the principle that we are using here is the Imbert-Fick law, where pressure is equal to force upon area. Area is fixed, which is equal to 3.06 mm. As well as you should also know the name of the stain. Here also we are using the fluorescein stain with the cobalt blue. filter. Fluorescein stain along with the cobalt blue filter. Fixed area important है. It is a kind of fixed area tonometer, so it's a kind of variable force tonometer. Again, name of the dye, name of the filter is also important. It is done in the supine position. Now, how can you differentiate between VKC and GPC? And literally, both are having large polygonal raised areas. So, same image hogi, we will have polygonal raised areas. Okay. Now, how can I differentiate then whether it's a vernal keratoconjunctivitis or it's a giant papillary conjunctivitis? Vernal keratoconjunctivitis will be common in young males, where we will have a type 1 hypersensitivity reaction. It would be a exogenous allergy. It will be a exogenous allergy, and here you will also get complaint of itching. We will have complaint of itching along with the ropey discharge. Complaint of itching along with the ropey discharge. While in cases of the giant papillary conjunctivitis, you will get history of localized allergy. We will get the history of the localized allergy. Localized allergy may it can be due to the contact lenses. Due to contact lenses can be given in the question. Some sutures can be given in the question, or even some prosthesis. Even some prosthesis, right? Now, next is the pterygium. So, we cannot forget the pterygium. Pterygium is again, a topic which always give you a question, especially in the FMG examination. So, in cases of pterygium, what is happening? We are having this wing-shaped fold, right? Which is having this one, then 2 is the neck portion, and 3 is the body portion. So, this is the apex, this is the neck, and this is the body. So it is a growth basically over the cornea. Conjunctival, it's a conjunctival growth over the cornea, and due to this growth we can have the astigmatism. Due to this growth we can have astigmatism, and basically this astigmatism will be the most common cause of the diminution of vision. The most common cause of the diminution of vision in the patients of the pterygium will be the astigmatism. Also, it is more common on the nasal side. More common on the nasal side. Okay. Next is the acute hemorrhagic conjunctivitis. Recently, there was a question on this acute hemorrhagic conjunctivitis in essay 2025. So quickly we can revise the causes of this acute hemorrhagic conjunctivitis. May we have the picoRNA virus family. picoRNA virus family is there, especially the enterovirus. Especially it is the enterovirus type 70 that is there. We have adenovirus that can be there, as well as the coronavirus. PicoRNA virus family is mostly causing acute hemorrhagic conjunctivitis. Bacteria are not causing hemorrhages. There is only one bacteria which is causing, that is pneumococcus. Apart from that, the bacteria are not causing hemorrhagic conjunctivitis, and these are the viruses which are causing the conjunctivitis by the hemorrhages. Well, when I'm talking about the follicular conjunctivitis, it can be by the adenovirus, it can be herpes virus, it can be coronavirus. These three are the most important viruses which are causing the follicular conjunctivitis, and adenovirus can occur in the form of epidemics also, or it can give you the typical pharyngo conjunctival fever also. Pharyngo conjunctival fever. So depends upon which species it is. Yes, there can be power change due to the pterygium because of the astigmatism, definitely, right? Next, if I talk about the ocular tumors, so ocular tumors can be of two types. We can have primary tumors, we can have secondary tumors. Secondary tumors are the metastatic tumors which are actually more common in the eye. But if they are asking you a question on primary tumors only, then you will have to see whether they are orbital tumors or they are the ocular tumors. Now, whether they are orbital tumors or whether they are ocular tumors, you have to see in adult, children, adult and children. So likewise, 4 type of question size flow chart say you can solve so many questions. Orbital tumors which are found in adults will be cavernous. It can be the cavernous hemangioma. Orbital tumors in the children can be rhabdomyosarcoma. Ocular tumors in the adults can be malignant melanoma, and in the children it is the retinoblastoma. So even one word change will also change the answer. Next, the difference between symblifron and ankyloblifron. Blifron and whether it's ankyloblifron, it's a symblifron, it's adhesion. Symblifron may we are getting the adhesion which is between the palpebral and the bulbar conjunctiva. So whenever there is a adhesion between this palpebral and bulbar conjunctiva, that is symblifron. While if they are having the adhesion between the upper lid and the lower lid, that is called as ankyloblifron, because that will be present at the angles. Okay. Now, very important, Fisto classification, that is there in the trachoma. So when we have the patients from trachoma, we have WHO staging a Fisto for follicular, and we know the type of follicles which are found here are the sago grain follicles. Then we have I. I is for the intense inflammation. Then we have S for scarring, because here we are getting the arts line. We are getting the arts line. Then we have T. T for trichiasis. T for trichiasis, and O for opacity. Opacity of the cornea. And basically, because it is causing the opacity of the cornea, this is actually responsible for blindness, and that is how trachoma causes the blindness, and why it was the most common infection which is causing blindness in India. Next is your safe strategy. Safe strategy is again used for trachoma, whereas is for surgery. A for antibiotics. A for antibiotics. F for facial cleanliness. Facial cleanliness is there. And then we have the E. E for environmental hygiene. We have the environmental hygiene. So these words are very fixed. Surgery is for the trichiasis. Basically we are doing this for the trichiasis. Then anti-glaucoma drugs. Certain things more about anti-glaucoma drugs may that you have to remember. So which anti-glaucoma drug is causing the neuroprotection? I told you is bromonidine. It is also contraindicated in infants, which is contraindicated in infants. So it is again the brimonidine. Another important thing, brimonidine is contraindicated in infants due to the CNS depression. It causes the CNS depression, and due to the CNS depression, it can cause apnea as well as drowsiness. Apnea as well as drowsiness. One is this, and second important thing is that which anti-glaucoma drug is working, which is working by increasing the trabecular outflow. So this is your netar-sudil, Rho kinase inhibitor. Rho kinase inhibitor is there, where we have the netar-sudil. Then next is your penetrating trauma. Penetrating trauma may very important are the do's and the don'ts. We have the do's and the don'ts. So whenever we have a case of penetrating trauma, I should do the survey of the patient. We have to take the visual acuity of the patient. We have to start with the antibiotics, and then we can refer to the ophthalmologist. Then we can refer to the ophthalmologist. While Don't smell, whenever you look at a patient and he is having some iron nail, then everything you feel like doing should not be done in this patient. So don't actually touch the eye, don't rub the eye, don't wash the eye, don't cover the eye, and also uh, don't remove the foreign body. Very very important hai, don't remove the foreign body, because when you remove the foreign body you are converting it into a open wound may we can have a lot of infection, we have a lot of chances of perforation. So you don't have to remove, you are referring to the ophthalmologist, we can do the CT scan, and under the OT setup we are going to remove it. Then next is the blunt trauma. Blunt trauma may you have a lot of signs. So I have already talked about the cataract. Like we have important thing that is called as the raccoon sign. We have the raccoon sign or the panda sign. We have subconjunctival hemorrhages that can occur due to the blunt trauma. We have the Voschius ring can occur due to the blunt trauma. We have what you called as the iridodialysis. Iridodialysis is there, which can lead to the D-shaped pupil, and another important thing is hyphema. So whenever we are having blood in anterior chamber which is due to trauma, it is due to the major arterial circle. It is due to the major arterial circle. Next is your chemical injuries. So nowadays we have questions like, if you look at the insect paper also, there was a question related to chemical injuries. It could be the acid injuries also, and it can be the alkali injuries also. The first thing is the conjunctival irrigation. So any kind of acid is there, you have to do you have to do the intensive irrigation of the conjunctival sac, which can be done by normal saline, ringer lactate, or basal salt solution, anything we can use. After you have done this, then we can do the double eversion. We can do the double eversion of the upper lid. Basically we want to remove the deeply embedded particles. Then we will do the debridement, where we can do the removal of the dead tissue, and only then we have to give the topical drugs. Now the different drugs that you can give to this patient. Topical drugs may, I can give the tetracyclines. Tetracyclines are not basically as an antibiotic, but as a drug which is protecting the perforation. We want to give the steroids because there is lot of congestion. We will give the citrates also. That is a definite antidote. Then Snellen's chart. So we cannot forget the visual acuity. Snellen's chart hai. And the normal visual acuity that we are taking here is 6 by 6, or it is 20 by 20. Why we are taking 6 by 6? Why we are taking 20 by 20? Because the normal distance at which the patient has to stand, this normal distance is 6 meters or it is 20 feet. Either it's 6 meters or it is the 20 feet. And a very very important thing is the minimum angle of resolution, which is equal to 5 minutes of the arc. So this is the smallest angle which a letter should make at the nodal point, that is the center of the lens, in order to make this letter visible. Then we come to the hyphema and hypopyon. So hyphema, guys, is the blood in the anterior chamber, right? While hypopyon is the pus in anterior chamber. So I have already discussed that the hyphema is occurring due to the blunt traumas, due to the rupture of major arterial circles. Hypopyons, bacterial keratitis may we have talked about the fungal keratitis and also the bacterial endophthalmitis. Then next is the thyroid eye disease. Now this was the most common cause of the proptosis in the adults. It can be occurring in The hyperthyroid status, if we have the hyperthyroidism, 90% of the people will be hyperthyroid, but 6% will be euthyroid also. So it's not compulsory that my patient should be having hyperthyroidism in order to have the thyroid eye disease. And 4% can also be hypothyroid. Order of muscles will be I am slow. So you should also know the order of the involvement. Order ho gaya I am slow. It is inferior rectus, then we have medial rectus, then we have superior rectus, lateral rectus, followed by the obliques. And the most important thing actually that you get here is the sparing of the tendons. It is the sparing of the tendons. So tendons are not involved, and due to this is also called as the Coca-Cola bottle sign. Then coming to blindness. So again, recently there was a question on blindness. So what is the exact definition of blindness? I'll say talk about the WHO definition. Visual acuity which is less than 3 by 60. So visual acuity should be less than 3 by 60, which is best corrected. It should be best corrected visual acuity in the better eye also. So because of these two words, so many of the students got confused in the definition, and there were certain problems. It should be corrected also, and it should be in the better eye also. That is the definition of blindness. Then the Bitot spots. Bitot spots are the white foamy spots. These are the white foamy spots. They are found in the vitamin A deficiency. These are the white foamy spots found in the vitamin A deficiency, more common on the temporal side. These are more common on the temporal side of the conjunctiva, and basically they are occurring due to the hyperkeratosis. They are occurring due to the hyperkeratosis of the epithelium. So if I talked about the normal epithelium, like normal epithelium was non-keratinized stratified squamous epithelium. This is actually the hyperkeratosis which is occurring. Then next is about the lid deformities, trichiasis, like we have already talked about. So another is the distichiasis. Another is the distichiasis, where we will have two rows of the lashes. Di means two. So if I am having two rows of the eyelashes, it is called as distichiasis. I can have madarosis as well as the poliosis also. Madarosis is the loss of the eyelashes. If there is a loss of lashes, it is madarosis. If it is graying of the lashes, graying of the lashes will be called as the poliosis. Then high myopia. Now high myopia case certain important signs where we are having myopia more than -6 diopters. So I am going to have the tigroid fundus, that is also called as the tessellated fundus. We are having the posterior staphyloma. Another important thing is the posterior staphyloma that is there. We have the what you called as the vitreous degenerations can be there. We can have night blindness because we have the peripheral degeneration, so this patient can also present with the night blindness. And finally the patient can also present with a cataract. So the kind of cataract which is found here is the complicated cataract. Can you tell me the two important signs of complicated cataract? Do you remember the polychromatic luster and the breadcrumb appearance? And the morphology of the complicated cataract will be the posterior subcapsular cataract. Then last but not the least, so a very important thing, how to calculate the refractive error. So whenever it comes the calculation of the refractive error from the retinoscopic finding, guys, always remember that refractive error is equal to the retinoscopy. Is equal to retinoscopy. Retinoscopy will be given to you minus the distance factor. Minus the distance factor is there, and minus the tonus. This is the total formula. Retinoscopy will be given to you, like for example it could be +3 and +5. I am taking a simple example. Suppose it is like this. Distance factor, so distance factor is 1 upon distance. and tonus will be given to you, or they will say that they are using atropine. So atropine ka tonus is 1. So if I'm taking a distance of 1 meter and we are taking the tonus also 1 because it is atropine. Now how to calculate the refractive error? From a distance of 1 meter, so minus 1, and from using atropine also minus 1. Minus 1 and minus 1. Okay. So retinoscopy minus the distance factor minus the tonus. So now you are having what? You are having plus 1 and plus 3. You are left with this. Now what you have to do, one side pe we are having plus 1 and one side pe we are having plus 3. So we are having difference of refractive error. Difference of refractive error means astigmatism. So we have both spherical error also and we have cylindrical error also. Yes, you can take it other way also. So we will get two combinations. One is this where I am taking plus 1 as the diopter spherical. So diopter spherical है, oblique diopter cylinder minus diopter spherical at perpendicular axis. This is the formula. Now how to utilize it? So value of diopter spherical means plus 1 we are having, then cylinder is 3, 3 minus 1. So this will be plus 2 diopter cylinder. Perpendicular axis hai, this is your 180, so perpendicular is 90 degree. So one of this will be plus 1 diopter spherical and plus 2 diopter cylinder at 90 degree. You can write it like this, that we are having plus 1 diopter spherical and plus 2 diopter cylinder at 90 degree. Or I can use this also as diopter spherical, so it will be plus 3 diopter spherical, and then we are having this as the cylinder. Now it is 1 minus 3, so now it will be minus 2, then it is minus 2 diopter cylinder, and this is 90 degree, therefore perpendicular is 180 degree, at 180 degree. So these are the two things, either we can use this or we can use this. These two are there, and you are done. Now sometimes in the options they have given you only one. If they have given you only plus 1 diopter spherical, no need to calculate the other one, and vice versa. If they have given you the options which are having both, then you will have to calculate. Number second thing is that if you have calculated for one, then you can just change this sign and this axis and you can get the next one. So when I am using plus 1 diopter spherical, here we are having plus 2 and at 90 degree. So if I am using another one plus 3 diopter spherical, then change this sign and change this degree and you will get the second prescription, and we can save the time in solving for the second. So here we come with the end of the first 50 pointers, the 100 of the session, 100 most important pointers of the ophthalmology. This is your first 50. Very soon we'll be doing the second part also, in which we are doing the next 50 important pointers. I hope you had enjoyed this. PDF will be given to you after the session, and do join the Telegram group and the Insta handle. Here you are going to get the PDFs also, and let me know in the comment section what are the other things you want me to cover in the second session, and I'll see you guys. Thank you so much. Bye bye guys. I hope this will help you, and definitely very soon I'll be coming for the second session too. Bye bye. Good night. Happy ophthalmology.